Everything pictured here is part of the digestive system, all the way from the mouth, the oral cavity, to the anus. Everything in between, pictured here, is part of the GI system. So we do have accessory digestive organs, including the liver, gallbladder, and pancreas. We'll go over what each of those do. We're going to start today in the oral cavity. As you'll come to find out, digestion starts in the mouth, and we're going to go down from there. So throughout the GI system, the gross structure is essentially shown here. We have different layers. We have mucosa, submucosa, muscularis, and serosa. And you see in the mucosa, we have epithelial layers, so we can secrete, we can absorb, but the big moneymaker here is in the muscularis. And so, as we saw in the cardiovascular lecture, these tubes are lined with muscle. So there's a very unique muscular structure to the GI system. We have two layers of muscle in the muscularis. So the muscularis is shown down here. We have a circular layer that wraps around our tube, and a longitudinal layer, which goes alongside. And so we'll see how these different layers will really come into role in peristalsis and muscular control of pushing our food forward throughout the GI system. So great question. How in depth do we need to memorize all this? Not incredibly in depth. I just here to kind of orient yourself, introduce you, make you a little bit more familiar. We have multiple layers. It's not just one layer of tissue. That's this tube that's dangling throughout your body. And then it's even not dangling throughout the body. We have the serosa, which is an outer layer of connective tissue, which is the beige color here, and that holds everything in place. So it's not just one goopy mass of tubes that just sits in your stomach. It has a specific place where it needs to be. But the biggest thing here in depth is, hey, the muscularis layer. We have two layers here, the circular and longitudinal muscle. That's what I want you to take away from this slide. Those two layers of muscle are huge. So the functions of the digestive system, motility. So the motility that comes back down to those two layers of muscle, the circular and the longitudinal, and peristalsis. And we're going to start with digestion. So digestion starts in the mouth, and it will occur throughout the GI system. Secretion and absorption. So this is a great time to talk about a tube within a tube system. So the human body is organized as an outer tube. Say this is the skin, right? That's the outer tube. We have an inner tube. This inner tube is our GI system. So this is the GI tract right here. So anything out in this area or in the GI tract is considered outside of the body. What's inside of the body are these areas right here, in between the skin and the GI system. So humans are organized within a tube, inside a tube system. And so when we talk about secretion and absorption and directionality, when we secrete things, we're actually secreting things into the GI tract, and absorbing, we're pulling from the GI tract. So secretion and absorption are directional terms. Secretion is outside into the lumen of the GI tract, and absorption is pulling it in from that lumen inside the body. Yeah, so there is a term here. So we just message in the chat, exocrine. So exocrine signaling is out, is secretion. So we'll talk about exocrine function specifically in the pancreas today. At the very end of the GI tract, as we're all familiar with, storage and elimination. So, anybody have any questions on what I mean by tube within a tube? So when we talk even in the renal system today, that's important for directionality and what absorption is and what secretion is. All righty. So motility, let's talk about that peristalsis. What exactly is a peristalsis? So it is a stepwise process of muscular contraction and relaxation that pushes our food in one direction. So, yeah, when we're sitting up eating, when we swallow, we do have the help of gravity helping the food down the esophagus. But when we get into those small intestines, right, and when we're kind of zigzagging everywhere, and we get into large intestines, and we actually have to move up the ascending colon, how do we work against gravity? And so this is where, the muscular control is, all on its own. It has to do what it has to do. So what happens, so we're going from left to right. So I'm going to try to, it's kind of hard to show in static images, but we are moving from left to right. We ingested the food over here and it is passing through our GI system. So this is our ball of food right here in this grayish color. I will refer to it as a bolus. It could be referred to as chyme. So these are all different interchangeable terms you might see for what is in your GI system. You have this bolus of food and this, GI tract. What you're going to have is you're first going to have contraction. These are all smooth muscles, right? So these aren't skeletal. They're not on the skeletal system. You're going to have contraction of the circular smooth muscle behind it. So this area of circular smooth muscle is going to contract behind our bolus of food. It's going to prevent it from moving backwards. After that is contracted, our longitudinal layers in that area are going to contract as well. Okay, 1 second. I need to move the chat box out of the way. So there are some questions. So the contraction is making the muscle smaller. So when we contracting the circular muscle, it's essentially constricting so if we have the cross section of the circular muscle here, as we contract it, it's going to, it is on different colors. Let's redo that. As we contract it, it's going to make it smaller behind the food so the food can't move backwards as we reach the next step. So yes, cool. And then smooth muscle versus multi-unit. And so the different classes of muscle are smooth, skeletal, cardiac muscle. So we just have different muscles here, different directions, working together, different types of smooth muscle. So these are both smooth muscle types. We have circular and longitudinal that are working together to reach a common goal, and that's pushing our food forward. So what's going to happen is as we contract behind it, the longitudinal muscle, the longitudinal layer will contract. So what that's going to do is say we have another region of circular over here that we're trying to reach. Contracting the longitudinal muscle will bring this layer closer to the layer that's already contracted. And so we have that original layer that was contracted over here. And once we bring the longitudinal layer over and we bring the circular layer next to the circular layer that we already contracted, this new circular layer will contract. And as it contracts, the longitudinal layer will relax, and that's going to expand the tube. So what that's going to do is it's going to pull this circular layer in this direction. And as it pulls it in that direction, it's closed behind the chyme of food. So it's going to, as the longitudinal layer relaxes and pulls this circular layer back to where it was, as it's behind the food, it's going to push the food forward as well. And so it's kind of like when you're wearing a long sock, you can scrunch up the sock itself, and then you can put your toes at the very end, and then you can just drag the sock along your foot. If you have a tennis ball and a long sock, if for some reason that's what you do, you can pinch behind the tennis ball to move it forward. And that's essentially what's happening here in peristalsis. So is it like the concept of collapsing tunnel that you see in those Hollywood movies? I don't think I have ever seen a Hollywood movie with a collapsing tunnel. Now let's see. It is like putting a string back through your hoodie once it comes out. Exactly, yes. The ball and sock analogy. I mean, it's kind of weird to put a ball in a sock, but yeah, that works. That's how I remember it. I don't know why I've put a tennis ball in a sock, but I have. Okay, let's see. The longitudinal layer relaxes in front of the bolus but contracts behind it. So a longitudinal layer actually is contracting alongside the bolus. It's the circular layer that contracts behind it. So we do have that circular layer that contracts behind it. The longitudinal layer, which is this outer layer, contracts alongside that bolus and is going to pull a future circular layer closer to where it's already pinched. So then that circular layer is going to contract, pinch off behind the food, and then as the longitudinal layer relaxes, it's going to push it forward. So the longitudinal layer is changing the length of the tube in this direction. And then the circular layer is contracting and changing it in this direction. So together, they're taking turns in contracting and relaxing. Is you're essentially creating a wave of motion that is pushing the chyme along the GI tract. So this happens starting in the esophagus. So the longitudinal layer directs food forward and the circular layer prevents it from moving backwards. Essentially, it's kind of working like that. You boil it down, but what the longitudinal layer is doing is it's bringing circular layer behind it to prevent it from moving backward. And as it relaxes, it's indirectly pushing the chyme forward because that circular layer that was over here needs to return to where it was. And so it's going to return to where it was. And as it does that, it's contracted behind and it will push the chyme forward. I have a lot of drawing on here. Clear that out. Yeah, some people have, it starts in the esophagus. And so to kind of give you a sense that this needs to happen, some people have an issue with esophageal dysmotility, where when they eat, their chyme gets stuck in their esophagus. When it gets stuck in the esophagus, gravity's only doing so much. And there's a little bit of a delay, and that causes a lot of issues if you have esophageal dysmotility. So we need peristalsis even starting in the esophagus, which is, the very top. Usually when you're eating, you're sitting upright. So there will be gravity aiding, but gravity alone can't do the job. We need peristalsis. All right, any other questions on peristalsis? Peristalsis is just the process by which circular layer and longitudinal layers contract to relax to push the chyme forward. Alrighty. Get rid of the drawing. So ingestion. When we eat, everyone loves to eat, right? So we got start at the mouth, we go past the pharynx, down the esophagus. So we actually do have digestion that starts in the mouth. Two types. We have mechanical and chemical digestion that occurs in the mouth. So the mechanical digestion is you chewing, right? As you bite down on your food, you are starting to digest it into smaller parts. It's starting to lose its structural integrity. But you do also have a enzyme in your saliva. That enzyme is amylase. So you're going to start to digest starches. If you ever put a saltine cracker on your tongue, it starts to dissolve. And the reason why it's starting to dissolve is the amylase in your saliva is starting to digest it. So you're not going to get any digestion of proteins here. You're not going to get any digestion of lipids. You're only getting digestion of starches here. Yeah. So you do have enzymes in your saliva. So you're having both mechanical and chemical digestion in your mouth. So it's where digestion is starting. As we swallow, we pass by a little flap called the epiglottis. So as you swallow, the epiglottis will cover your respiratory tract. It's going to cover your trachea so that you can, when you swallow, food goes down your esophagus and not your trachea. Some people have epiglottis issues and they can accidentally swallow food into their trachea. That's not good. That will cause that's aspiration. Aspiration can lead to pneumonia. So when you're older, there's a lot of older folks who have issues with swallowing called dysphagia. And when that happens, so they accidentally aspirate a lot of their food, get aspiration pneumonias. When you do a bronchoscopy and try to clean out their airways. The cultures grow food and vegetable matter. It's lovely stuff. But once let's say the epiglottis works, we're going to move into the esophagus. So the esophagus is this long tube right here. You will start to see peristalsis. You're going to have the muscular contraction as we propel the food forward and into the stomach down here. So we do have sphincters, different little muscular kind of like barriers that prevent food from going the wrong direction, or the wrong direction is back up. So when you have food that goes back up, it breaks through the esophageal sphincters, both the upper and the lower esophageal sphincters. And when that happens, you get acid reflux, or you start to get a more encompassing term called GERD, or gastroesophageal reflux disease. There's a question, isn't the anus a sphincter? Yes, there is an anal sphincter as well. There's sphincters throughout the body, not just at the anus, but we have some in the esophagus as well. We have esophageal sphincters. So if we do have acid reflux and chronic acid reflux, you get gastroesophageal reflux disease, or GERD for short. So let's type in GERD in the chat box, just so you know what I'm saying. So GERD is not something you want. GERD can cause a lot of issues. You can accidentally have microaspirations, where if you have acid reflux, it can go up past the esophageal sphincter and actually get into your trachea and cause issues. A lot of times, one of the 3 most common causes of chronic cough is chronic GERD, which is very interesting. So it can cause microaspirations. You get aspiration pneumonia from uncontrolled GERD. Pyloric sphincter. Pyloric sphincter is a good sphincter. That's at the bottom of the stomach. We'll go through that as well. But yeah, ingestion, esophagus. You have GERD. They're going the wrong direction. We don't want GERD. So as we move past the lower esophageal sphincter, we go into the stomach. So what is the purpose of the stomach? Stores food. We start to get digestion of proteins. And so in the mouth, we had digestion of starches, right? Now we're going to digest proteins. And that's because the stomach has an enzyme in it called pepsin. And so we'll talk about what type of cells line the stomach, but we release this inactive enzyme called pepsinogen. And the acidic environment of the stomach is a pH of 2. The acidic environment activates this pepsinogen. Pepsinogen cleaves itself and turns itself into pepsin. And so pepsin is a protease. And so you'll start to denature and digest different proteins. You'll not be digesting starches here. You'll not be digesting lipids here. In the stomach, you only have digestion of proteins. But the acidic environment also kills bacteria. And so all the bacteria on your food that you eat, most times it will be able to be killed by the stomach. So there is an immune function to the stomach as well. So in the mouth, we're trying to digest starches. You also have mechanical digestion. But in the stomach, you're no longer digesting those starches. You're just digesting proteins. There is no absorption in the stomach. And the reason why is because you have this thick lining of mucus. Why do we have a thick lining of mucus? And that's to protect the stomach lining itself from the acidic environment. So if we didn't have a thick mucus lining, we would have a lot of different spots along the stomach lining where the acid would kind of eat away at it. And there are some nonpolar substances that can be absorbed through that mucus lining, including NSAIDs like aspirin and alcohol. So there's a couple things that can be absorbed throughout the stomach lining. Let's see. There's a couple questions. So the cardia is just a region of the stomach. So the cardia is just so the lower esophageal sphincter is right in this area. The cardia is just a region of stomach. You don't really need to know the regions of the stomach, including the fundus, which really just stores food and stores specific gases that get produced by the breakdown of the food by the acid. You don't need to know what an antrum is. I'm just this is here for your anatomical purposes. And the very end is the pylorus. So the pyloric sphincter occurs right here. So this is the pyloric sphincter, some people's favorite sphincter. Okay. Let's see, there's some messages. Oh, I see. Okay. All right, let's move past the stomach. We'll pass the gross structures of the stomach. Let's look more at the lining. So there are different cells throughout the stomach, in the stomach lining. First, we do have goblet cells. So goblet cells do exist in all regions of the body that produce mucus. So you have goblet cells in your airways, you have goblet cells in your stomach, and throughout the GI tract. And so anywhere there's where you find mucus, you'll have goblet cells. But in the stomach, where we also have beneath the goblet cells is parietal cells. And parietal cells are the acid producing cells. They'll produce hydrochloric acid. So stomach acid is hydrochloric acid. And we'll see how that is made in the next slide. The chief cells are the types of cells that produce the pepsinogen. So pepsinogen is that inactive enzyme that once it gets into the acidic environment, that is the gastric pit, it'll cleave itself and become pepsin, the protease. Okay, just make sure I'm not missing any side conversation here. Cool. And then we have D and G cells. And so D and G cells are, we'll kind of circle back around to them at the end of the GI lecture. They are cells under control of the hormone and nervous system. And so when we do want to activate stomach acid production, the D cells will signal to the D cells to produce somatostatin. When we'll produce it, we'll signal to the G cells to produce gastrin. So when we want to produce that acid because we're getting ready to eat. When we're not eating, we already ate, we want to stop acid secretion, we'll signal to the D cells. And so this is at the level of where the nervous and endocrine systems control acid production and stomach function. But the biggest three types of cells I want you to know are goblet, parietal, and chief cells. If for some reason your brain is at full capacity and you can't remember D and G cells, that is fine, but do know the other three. D and G cells are good to know, but for sure know the other three. I have no mnemonic for these, unfortunately. If someone has a magical mnemonic for these guys, that would be awesome. Alrighty, so why is digestion of various things staggered throughout the digestive system versus occurring in one place? That's a fantastic question. We do see more, as we get into the small intestine, you'll have digestion of all three types. I don't know any evolutionary reason off the top of my head why we digest starches in the mouth or why it's just specifically proteins in the stomach. So yeah, I mean, when we get the small intestine, we'll have all of them being digested at the same time, but through why they're being staggered so far, I don't know of any evolutionary benefit to that. Okay, chief secretes pepsinogen. Yes. Okay. Alrighty. Okay, so how do we actually produce stomach acid? So that's kind of an interesting problem here, right? Acids, for the most part, is harmful to the body. So we don't have acid free floating around. So how do we do that? So the parietal cells do that. And so what they actually take is they take water and carbon dioxide and they produce hydrochloric acid through that. So we take just free floating chloride that's in the blood, and then we break down the water, the carbon dioxide to create free protons, and we pump the free protons and we shuttle the chloride from the blood because we do have chloride in the blood. It follows the sodium, right? Sodium chloride. So what we're going to do is in the parietal cells, they have a specific enzyme called a carbonic anhydrase that can produce those free protons that we can shuttle into the gastric pit. This is the mechanism isn't super important. Just know where it comes from. Where does this hydrochloric acid comes from? Right. So in the parietal cells, we do that with carbonic anhydrase. We take that water and that carbon dioxide, create that free proton right in here. We're going to shuttle that free proton into the gastric pit, as well as these chloride anions that come from the blood. And so let's say we have GERD, let's say we do have bad acid reflux. When we don't want to have so much stomach acid production because we're having so much of it come back into our esophagus. One of the types of medications that we can take for acid reflux are called PPIs, or proton pump inhibitors. Which they'll actually come down and do is they'll inhibit this proton pump right in here. So we stop producing the acid themselves. The other type of acid reflux medications are H2 blockers, so histamine 2 blockers that will prevent, on this side, they bind to this and prevent parietal cell activity. They don't actually block the PPI itself. And H2 blockers, like if you ever heard of Pepcid, because it is a histamine 2 receptor blocker, it actually has some sort of allergy component too. So it has some side anti-allergy effect to it as well. So we got past the stomach. Briefly, we're going to visit some accessory organs. We have the liver and the gallbladder. And so the liver is going to have capillaries from the stomach and from the small intestine. As you absorb things, as you start to have absorption of nutrients, everything's going to go to the liver. Anything that you absorb from the stomach and the small intestine, it'll pass through the liver. So the liver will detoxify anything. So it has to go through liver processing. So most medications, when you take them orally, they have to be processed by the liver. So sometimes pharmaceutical companies will take advantage of that, and whatever we ingest orally maybe isn't the active form, but it knows what the liver will do to this molecule, and whatever the liver has done to this molecule has made it active. So that's something to take into consideration. Sometimes the liver makes some drugs less potent because it modifies them. I know if you ever think of, marijuana itself. So if you're from California, it is legal and there's no stigma over here. But if you're from somewhere else, I'm not advocating for or against it, but if you smoke it, you're having the THC that's being absorbed through your lungs, right? You're not having the liver process it. But if you eat marijuana, it has to be processed by the liver. So what the liver does, it creates a metabolite from that THC, and that metabolite is actually a little bit more psychoactive than smoking it. So if you ever eat it versus smoke it, there's different effects because of the liver. And so I don't do that myself, but people, for some reason, that resonates with people, and what the liver does. Let's see. So these are functions of the liver. I'll go into the gallbladder real quick. But what the liver also does as it detoxifies things you eat, it just detoxifies what's in the blood as well. So the liver will also get rid of old red blood cells. So red blood cells we don't need anymore. We'll break that down. And what that's going to do is it's going to shuttle that into the gallbladder. So we'll go into what's in the gallbladder next slide. But the gallbladder has no specific function here. What's happening is the liver is taking stuff out of the body, and it's going to store it in the gallbladder for right now. We'll get into what it does. The liver also secretes and stores glucose, cytogluconeogenesis, and it produces a very interesting protein called albumin. So albumin is an inert protein. It has no enzymatic function, but it is one of the most important in the body. So the albumin exists inside the blood to regulate osmotic pressure. So what I mean by that is the water throughout your body, and the water throughout just the nature in general, it will travel from least concentrated in terms of solutes to most concentrated to balance out osmoregulation, to balance out the osmolarity. So if we have something that is has a lot of solutes in it, the water will travel towards that. And so what the liver does, it produces this protein called albumin to give the blood an osmotic pressure. It keeps the water in the plasma into your blood vessels because it has to balance the osmotic pressure of albumin. So if let's say you don't have albumin, people that have either alcoholic or non-alcoholic liver cirrhosis, and they have poor liver function, they can't produce albumin. And so what happens is the blood essentially is starting to lose the osmotic pressure. You'll start to have a lot of leakage where the osmotic pressure is taking the water from the blood and kind of shifting it into the interstitial spaces. So you have these people with collection of water in weird places. One of the most common is in the stomach. So they're very thin everywhere else, but the stomach balloons up. And the stomach balloons up because there's collection of water, and that's called ascites. Very interesting. So albumin is quite an important protein. So if you're having poor liver function and not producing albumin, that can cause a lot of issues. So that's a type of edema. There's also different types of, like let's say lower extremity edema. That's more not an albumin cause. That's more of a heart-related cause. Let's say we have right heart strain. We have backup of a pressure in the right side of the heart. You will have fluid shift into the capillaries, in the interstitial spaces of your extremities because we want to reduce the plasma volume because there's so much of a backup in the right side of the heart. So it does cause a type of edema, but it's more of a weird one that collects more so in the stomach. And so ascites is very, very interesting. Yeah. So GI capillaries are, that is a question, capillaries from the stomach itself and capillaries from the small intestine. And we'll talk about the capillaries that exist in the small intestine and the microvilli. And as we absorb things from our food, it goes to the liver to be detoxified. Like, what is a capillary? So capillary are these very, very small vessels. So if we go from the left side of the heart, we have an artery, right? So the arteries go to arterioles. The arterioles go into capillaries, and capillaries are essentially this very small vessel. They're very permeable to different nutrients, to different gases, and it's the site of gas exchange where we give oxygen to our tissues, where we take up carbon dioxide. We can give off different nutrients. We can take out wastes, and then the capillaries will transition and start connecting to each other to create venules, and the venules then combine and create veins. So the capillaries are the site of a lot of nutrient exchange, waste exchange. There are these very, very small and permeable vessels that are the barrier between the arterial and venous blood flow. Are the capillaries in the liver part of the hepatic portal system? So yeah, so what's going to happen is the liver has some really weird blood flow. As the capillaries in the liver, do their thing, instead of that blood going into systemic venules and systemic veins, it's actually just going to drain straight into the inferior vena cava via the hepatic portal vein. And so whatever's being absorbed and filtered throughout the liver, rather than join back into systemic circulation right away, it'll go straight into the inferior vena cava, which is shown right in here, the blue vessel. Any other questions on the liver? We'll talk about bile here next slide. No, so what is bile? And so one of those breakdown products of the liver, the red blood cell breakdown product, gets stored in the gallbladder. in the form of bile. So bile is made of two things, bilirubin and bile salts. So what is bilirubin? Bilirubin is the breakdown product of that hemoglobin. So when we do break down those red blood cells, we create bilirubin. And bilirubin is this orangish, yellowish, brownish substance that is very, very toxic to the body. So let's say our liver is not working. We have liver failure. What is one of the, just in like TV shows and whatnot, what is one sign of liver failure that is commonly gets dramatized on TV shows? Jaundice, exactly. When you start to have a yellowish tint in the skin, your eyes become very yellowish. And the reason why is because you're having bilirubin build up. So you're having way too much bilirubin because the liver's not able to clear it out and put it into the gallbladder in the form of bile. So the way we actually get rid of it is through bile, and we put bile into our small intestine and we excrete it that way. Let's say the liver stops working. So not only are we having hypoalbuminemia, which is we don't have enough albumin in the blood, we also have bilirubin breakdown, bilirubin buildup, sorry. And that is a very toxic substance. We don't want that flowing throughout the body. The other component of bile is bile salts. And so this is where we're getting more of a mechanical breakdown of now fats. So an issue with fats is the GI lumen is a very hydrophilic environment. So what do lipids do in hydrophilic environments? They clump up. And so how are we going to do a lot of chemical breakdown if we don't have a lot of surface area of our big globs of lipids? So what bile salts do is they have a hydrophobic side and a hydrophilic side, where the hydrophobic side can go and insert itself around these smaller balls of lipids, create a lot of small balls that can exist in a hydrophilic environment because of these salts have a hydrophilic side. What this does, that allows for an increased surface area to allow us to speed up lipid breakdown by lipases that we'll be introducing in the small intestine. So the two components of bile are bilirubin, is which we're going to insert into the small intestine so that we can excrete it out, and then bile salts, which aid in a more mechanical breakdown of fats so that the lipases have more surface area to work with. So this little lipid molecule was part of a giant glob of lipids, but these bile salts can come in and create little micelles around these lipids. Don't they test, let's see, for this in newborns as well? They have like bilirubin blankets to help with this. I actually don't know anything about bilirubin in newborns. I've never looked into that. That's very interesting. Yeah, so how do bile salts increase surface area? So let's say we have a giant glob of lipids. What bile salts do, and the reason why we have a giant glob of lipid is because lipids are hydrophobic in a hydrophilic environment. If we're in the GI lumen, it's a hydrophilic environment where we've just been through acids, which is very hydrophilic. We're now in the gastric lumen, which is very watery. That's going to be hydrophilic. And so these hydrophobic substances, because they don't like interacting with hydrophilic environments, will clump up. And so if we have this giant clump of lipids, the lipases that need to come in don't have a lot of surface area to work with because it's this giant ball. So what bile salts do is they can surround smaller pieces of lipid and create an essential pseudo-hydrophobic environment because it's being exposed to a hydrophobic side of this bile salt right here. So it's being exposed to that. And so you can now break these lipids into smaller little globs because now it thinks it's in a hydrophobic environment because of these salts. So what happens is now that we have a ton of smaller lipid globs, it allows for more surface area for the lipases to come and do their thing. Lipases break down lipids. That makes sense? Awesome. Cool. All right. Another accessory organ that is going to actually share a little duct with the gallbladder. So as we move into the stomach, we'll go into the small intestine here shortly. we are draining things into the small intestine. So the gallbladder will be draining from this bile duct. So the liver is going to store this bilirubin in the gallbladder, the bile salts in the gallbladder. That bile is going to be excreted into the small intestine via this bile duct. But it also shares a duct with the pancreas. And so the pancreas has two classes of functions. First is endocrine. We'll talk more about endocrine functioning in the endocrine lecture, but it also has exocrine. So this is also, in versus out, secretion versus absorption in the side of the body versus outside of the body, right? If we're excreting things into the GI tract, into the GI lumen, we're excreting it out of the body. So this is where, if the pancreas is going to excrete things into the GI lumen, it'll be exocrine signaling outside of the body. So it's going to exocrine signal or secrete a lot of different things. It's all kind of classified under this substance called pancreatic juices. Pancreatic juices contain water, bicarb, and then more enzymes. Now we're starting to get the digestion of everything in one place. So you're going to start releasing more amylase to digest starches. We now have a new type of protein, trypsin, a new type of enzyme that breaks down protein called trypsin. And we'll now have the lipases. So this is where we're going to start to get to see the chemical breakdown of fatty acids. And so why do we need even a new protein, right? So here's for new protease. Why do we need that? Well, first, what type of environment is pepsin active in? An acidic environment. So this bicarb that's being excreted by this pancreatic juices, which we'll see in a couple slides, is going to neutralize the stomach acid. So pepsin is no longer an active, really, or functional protease. So we need a new one. And so one that functions in a more neutral environment is trypsin. So trypsin is our new protease. So here, because of the pancreas, because of what it's excreting into the small intestines, we're now having digestion of all three types of substances. The exocrine secretion goes into the small intestine. Yep, pancreatic amylase would be exosecretion. Yeah, so it's exocrine because it's going into the GI lumen. And because it's GI lumen, because a tube within a tube organization, right? Whatever inside the GI lumen is not inside of the body. So it'll be exocrine signaling. So the small intestine, that's where we're at now. It exists from the pyloric sphincter, which is at the end of the stomach, all the way to the ileocecal valve, which the ileocecal valve is the border between small intestine and large intestine. So it is about 12 feet in length. It's very long. And so this is where we start to get a lot of absorption. So this is where absorption starts. Previously, we've only been talking about digestion. So we need absorption. So in the there's three sections of the small intestine: the duodenum, jejunum, and ileum. So this is where we'll start to see a lot of that absorption. Now that we're digesting a lot of, different types of compounds, we're able to actually absorb it now that they're small enough. So we'll start to absorb carbohydrates from the starches, the lipids that were broken down by the lipases and the bile salts. You can absorb amino acids and different ions. You start to absorb calcium, iron. The jejunum starts to absorb very similar things. And in the ileum, you start to get the absorption of those bile salts so you can recycle them, and then vitamin B12. And so you don't get a lot of absorption of vitamins into the large intestines. Vitamins aren't something I worried too much about taking for the MCAT. That might save you for one question, but they're not something that if you're short on time, not something I stress for you to know. Let's see. Yeah, alrighty. So when we talk about the GI capillaries, so when we do have inside the small intestine, we have a lot of these villi and microvilli. So we have, what that does is that creates a large surface area for absorption. And throughout these villi, we have these capillaries and lymphatic vessels. So this is where the absorption actually goes. So in these blood capillaries, because blood is a hydrophilic environment, we're going to absorb hydrophilic substances there. Amino acids, monosaccharides, different ions can be absorbed into the blood capillaries, and that will be going to the liver, straight into the inferior vena cava, and so on and so forth. But let's say we have those lipids. So if we're trying to absorb these fats, they don't like the hydrophilic environment. They don't like the blood. And so those can actually be absorbed into these central capillary-like structures called lacteals. So these lymphatic circulation has these vessels that'll go into these villi in the small intestine so that you can absorb these fats. So these are called lacteals, which is shown here in green. So this is how we get absorption starting in the small intestine. Something's interesting, right? So we have this acidic environment in the stomach. We don't want the lumen or the lining of the stomach to be exposed because of that acidic environment. But because the lining is not exposed, it's going to be really hard to absorb things. And so in the small intestine, we have a very, very exposed lining because we need absorption to start happening. So the acidic gas, juices from the stomach, that, stomach acid, as it's going to be emptied into the duodenum, that'll be a problem because it's very acidic and we have a very exposed area of the small intestines here. So we need to counteract this acidic environment of the stomach. And the way we do that is through those pancreatic juices. If you recall, there was water in the pancreatic juices, the different enzymes, but there was also bicarb. So the bicarbonate from the pancreatic juices will actually neutralize that stomach acid. And so we need to neutralize everything that's coming from the stomach so that we can safely expose it to the lining of our duodenum so that we can start to absorb. Okay. So the large intestines. Ooh, fun slide. Okay, so large intestines. Once we pass the ileocecal valve of the small intestine, past the ileum, we are now in the large intestine. So there are different segments of the large intestine. Let's go back up to a different slide that might show it a little bit better. Okay, so we start here at the ileocecal valve. We have the ascending colon. It's ascending right. It's going across the body now, the transverse colon, descending colon going down, sigmoid colon, then rectum and anus. And we also have the little appendix here that's hanging off the large intestine. We'll get into that in a second. Okay. One, two. This one. Okay. So the large intestine, you still will get some absorption, but the thing that's very interesting here, and then it might actually pop up on passages because it's a rather interesting frontier of where medicine is going now, is the microbiome of the small intestine. So we talk about gut bacteria, healthy gut bacteria, and we take probiotics. What we're talking about here is the bacteria that exists in the large intestine. So the microbiome plays a role in so many different things. So I have a friend that is in an addiction lab. And in that lab, they were researching nicotine addiction in mice. What they did is they took these addicted mice, wiped out their gut microbiome. So how do you wipe out a gut microbiome? Antibiotics, specifically vancomycin, which is very, very good at just wiping out gut bacteria. So they treat these mice with vancomycin and did a fecal transplant. They took the gut bacteria from a non-addicted mouse and put it into the addicted mouse. And that addicted mouse that has a new gut bacteria was no longer addicted to nicotine. So it's like, okay, wow. So our gut bacteria plays a role in addiction. What else does it play a role in? So I've read a study on athletic performance. And so you take people who are elite athletes, you take their gut microbiome and put it into people who are average Joes. The athletic performance of the average Joes was actually increased. Not necessarily the fine motor skills, but endurance and athletic performance was boosted by the gut microbiome. Mood disorders is what you study. So I'll let you share that in a second. What about MCAT performance? Hey, maybe that's a nice study. That would be a nice study. There's a study that I read on the role of the gut microbiome in autism spectrum disorder. So they took kids, did occupational therapy with them who have autism. People with autism have a very distinct gut microbiome. They wiped out their gut microbiome and replaced it with kids who don't have autism, and they found that their symptoms were actually relieved with changing their gut microbiome. But the issue is convincing Todd to give you his gut microbiome. Todd's microbiome is probably worth $1 million. This just got really weird, but yeah. So these kids that, had autism and got microbiome from kids who didn't, they saw an improvement in mental capacity and, social awareness, social cues. But the issue was, behavior also improved. But the issue was over time, the gut microbiome that it previously had repopulated itself. So that's what's kind of this weird thing. So is the gut microbiome causing the autism, or is the autism causing the microbiome? So why does, if it's the autism causing this distinct microbiome, why does changing it improve symptoms? So it's like one of those chicken or the egg type things, which is very, very interesting. How can you change your gut microbiota quickly? Take vancomycin and give yourself a fecal transplant. I mean, it can happen with one afternoon if you want to do it like that. Probiotics, yeah. Yeah. What mood, if you want to share, what mood disorder did you study with the gut microbiome? One that I haven't maybe heard of. You want to share?
I'll just speak because it's easier, but I was specifically looking at like anxiety and depression, like symptoms in mice.
Interesting. Okay, what type of results did you get?
So my results were not that significant with like the feed bacteria that I was, or the phyla that I was really focusing on. But one thing that was significant, which might not really make sense to people, honestly doesn't really make a lot of sense to me because bacteria is confusing, but just the proportion of firmicutes to bacteroidetes was increased. And that was significant. And actually, you brought up like autism spectrum disorder, and an increased ratio of that is actually associated with that. So it's kind of interesting. And we were focusing on the mice that had anxiety and depression like symptoms. And so the bacteria changed, which kind of indicated like other like mood disorder susceptibility and like other disorders in humans, if that makes sense.
Yeah, very interesting. Yes, different mood disorders, addictions, athletic performance. So many different things are just attributed to a very unique gut microbiome. And so let's say you have some really, really bad diarrhea, and that's going to wipe out your gut microbiome. So how does it repopulate itself? And this is one of those hypothesized functions of the appendix. So if we go back up to that little structure of the appendix, where did it go? This little guy hanging off the large intestine right here. And so one of the hypothesized functions of this guy is that it's a little safe haven for your gut bacteria to hide in and to kind of be that little storage for when you do have an intense diarrhea and wipe out your gut microbiome. Sometimes you can have very pathogenic gut bacteria. So if, let's say, we don't have a lot of water filtration, a lot of water sanitation, a lot of third world countries have issues with cholera. So if you have cholera, it's a specific bacteria called Vibrio cholera, has a cholera toxin. The toxin essentially upregulates the ion secretion into the gastric lumen. So because you're increasing secretion into the gastric lumen, the water is going to follow these ions. And because the water follows these ions, the water content in your large intestine will be higher and it'll lead to diarrhea. So how does diarrhea get rid of the gut bacteria? It's just there's so much water and it's just there's not a lot of salinity to it. It's just going to essentially clean it out. It will kind of give you a nice little cleanse. What sorts of biome large intestine questions could come up? It's a fantastic question. It may be they might give you just a passage on on a gut microbiome. They give you a study. They can do PCR to look at different bacterial colonies, just stuff like that. So it's more of there wouldn't be any like discrete questions on gut microbiome, but it's one of those things that can very well show up on a passage, and we don't want any jargon to get us caught up in a passage. So this is something interesting to be familiar with. The large intestine is very useful for that. And so you also, whether you absorb or don't absorb water content and whatever you ate can dictate the solidity of feces. So the final water content of feces is about 200 mils. If you are not absorbing that water, it'll be more, it'll be a little bit more watery. If you are absorbing too much, it'll be hard and not comfortable. So yeah, large intestine is actually more interesting than we give it credit for. It is essentially, yes, power washing, diarrhea power washes the large intestine. Okay, now once you get past the large intestine, it is everything is stored in the rectum. It's going to store until you're ready, and then hey, another sphincter. The anal sphincter will tie off the end of the rectum, and it will pinch off until you are ready. When we are babies, or in the end stage of our life, sometimes we lose control of the sphincter, and that is why we wear diapers. So the reason why we do defecate in diapers or and whatnot is the control or lack of the anal sphincter. Alrighty. Endocrine nervous control. So the GI system is under endocrine nervous control. There's 3 specific phases that I want you to know. So there's the cephalic, gastric, and intestinal phases. During the cephalic phase, it's when you see food, you smell food, or maybe you took one tiny little bite and all of a sudden, wow, you're hungry. You ever been had that feeling where you weren't hungry at all? You took a little bite of something, and you're just like, wow, I'm actually kind of hungry now. That is because you activated the cephalic phase. It's your brain is getting ready to eat now. So what it's going to do is it's going to tell your parietal cells via the G cells, right? It's going to signal the G cells to release that gastrin. That gastrin is going to tell your parietal cells to start producing hydrochloric acid. And the reason why is because we're getting ready for that incoming food. And you're also going to tell that chief cells to start releasing pepsinogen. So now we're going to start releasing these proteases, get them ready for the incoming food. Once you do decide to eat, you're going to have a food baby. The food is going to be in your stomach and have distension of the stomach. You've entered the gastric phase. So you're going to continue to release the proteases. You're going to continue to release acid, and you're going to denature the food to as much as possible. Once we are done with the gastric phase, we're going to enter the intestinal phase. So, and once we enter the intestinal phase, we have to inhibit gastric activity. We don't want any more pepsin. We don't want any more hydrochloric acid. We want that to stop. So what we're going to do is now we're going to signal that, hey, we're in the duodenum, so we need to release pancreatic juices. We're going to drop the pH so that we can start absorbing. And we're going to signal, hey, we need more lipases. So we're going to, signal for more of that. And so we're going to start to digest things in the intestine. So once we start with the cephalic phase, when you see food, gastric phase is once you have that stomach distension, intestinal phase is when you start to empty into the duodenum. The stretching of the duodenum will inhibit stomach activity and start to increase intestinal function. Alrighty. Excretory system, kidneys, renal system, in case we are confused. Any questions? We're making decent time here. All right. The kidneys are not as fun in terms of the gut microbiome, but they still don't get the appreciation they deserve. We have 2 kidneys. They look like beans. They are posterior bilaterally. If you have 2, everyone has 2, unless you have something going on. You can survive on 1 kidney. Just your filtration of the blood is not as solid. So the purpose of the kidneys, we're going to start filtering our blood, filter out different wastes, filter out ions, everything's dissolved in the blood. And so we'll talk about things being filtered out and being reabsorbed just to kind of demonstrate the importance of the kidneys. A unit of blood, if you follow one little spot of blood for 24 hours, it'll pass through the kidney about 40 times. So a lot of blood travels through the kidneys, and that's going to is going to filter out different things dissolved, different solutes, excrete waste, absorb some good things. We have two of them. They're posteriorly. They sit just underneath the rib cage. So if you have any like back pain on one side around the area of the kidneys, you might have a kidney stone. You might have blocked your ureter down here, which is not very comfortable. So the biggest two parts, we do have a lot of blood supply. We have a renal artery, renal vein, right? Arteries traveling away from the heart, veins traveling back toward the heart. But as we go into our renal capillaries, this is where all the magic happens. We'll zoom in here shortly. We'll filter everything out. The two main parts of the kidneys that are, we need to know. We don't need to know what a renal pelvis is, what the renal pyramid is. Mainly just the cortex, which is the outermost layer, the cortex around, and then the medulla. So the medulla is the inner layer. So the medulla is very, very salty. And we'll see why it's salty here in a bit. If we zoom in, we do have the functional unit of the kidneys called the nephrons. Each kidney has about 1 million nephrons. So we have 1 million of these guys, each kidney working together to create your urine. So in our nephrons, we do have these kidney arterioles that supply blood into the Bowman's capsule. So this is where we start to enter into the nephron. So the nephron starts the Bowman's capsule. We have these special types of capillaries in the Bowman's capsule called the glomerulus. The glomerulus is where we kind of kick out dissolved solutes from the blood. We enter this very twisty tubule that is next to the Bowman's capsule. If we have a twisty tubule next to the Bowman's capsule, it is called a proximal convoluted tubule. Proximal because it's close to the Bowman's capsule, and because it's all twisty, it's called convoluted tubule. Once we pass the proximal convoluted tubule, we'll enter down this giant loop right here. So this loop is called the loop of Henle. We'll talk about what the loop of Henle does for us. After the loop of Henle, we go into some more twisty tubes. But these are further away from the Bowman's capsule, so they're distal. So these are the distal convoluted tubules. And the distal convoluted tubules of many different nephrons will drain into a collecting duct. And so that, if you see here on a collecting duct, we do have little branches that are being cut off here, but these branches are from other distal convoluted tubules. So many, many nephrons drain into similar collecting ducts. And what the collecting ducts do is they'll all drain into the renal pelvis. And just to kind of keep in mind throughout the next few slides, throughout the loop of Henle, it is closely wrapped around by these paratubular capillaries. So the blood supply is following the nephron very closely. So anything we absorb will be brought into these paratubular capillaries and will leave, go out the renal vein, and head back to the heart. So we're going to zoom in more at the glomerulus themselves. We'll talk about glomerular filtration rate, which I mentioned briefly last lecture. But the blood's going to come in, it's going to go through the glomerulus. The glomerulus is going to shoot out what will eventually become the components of your urine into this proximal convoluted tubule. This is just a different diagram of it. Proximal convoluted tubule, down the loop of Henle, up the loop of Henle into the distal convoluted tubule and draining into the collecting duct. All right, so let's get into more of the nitty gritty of the renal system. So the roles in homeostasis, I briefly mentioned this last week. Urine output and the kidneys play so many different roles in homeostasis, specifically in regulating blood pressure, osmoregulations, how much stuff is being dissolved inside your blood, acid-base balance. what the acidity of your blood is. It can be dictated by your kidneys, and the removal of soluble nitrogenous waste. So protein breakdown. What do we do with all that waste? We create urea. We'll talk about that shortly. So this is a very important slide. If you were to ignore everything I said, this is one of the, I say, 3 most important slides of today's lecture. If you don't have time to review this entire lecture, definitely review this slide. There's a question real quick. Do we need to know the pressures of the glomerulus? We'll talk more about the pressures in the glomerulus a little bit on a few slides. You don't need to know the exact pressure, but we'll talk about that here shortly. So blood pressure regulation. How do the kidneys play a role in blood pressures? This is huge. This is called the renin-angiotensin aldosterone system. So you might actually see it as RAS, depending, I'll type in the chat. You might see it written as this. You might see it written as this, depending on the source. Renin-angiotensin aldosterone system. You might actually see it written as just renin-angiotensin system. So the kidneys play a role in blood pressure regulation through the renin-angiotensin aldosterone system. So what exactly is this? So this only kicks in if the blood pressure is too low. If we are hypotensive, the cells, the kidney arterial cells, will recognize that are right next to the glomerulus, will recognize, hey, the blood pressure is a little bit low. So what it's going to do is these cells are going to release renin. So this is our first player, right? Renin-angiotensin aldosterone system. It's going to release renin. Renin will signal to an inactive enzyme called angiotensinogen. Renin is going to cleave the angiotensinogen and create angiotensin 1. Angiotensin 1 will float around, and it'll be found by a dormant enzyme called ACE, angiotensin converting enzyme. So ACE is just sitting there. It's not being created. It's not being destroyed. It's just waiting for its angiotensin 1. It's going to change angiotensin 1 into angiotensin 2. So angiotensin 2 can do 2 things. It itself can create a blood pressure increase. How does it do that? It signals throughout the body. If you have angiotensin 2 flowing throughout your blood supply, it can cause vasoconstriction. It can tell your brain to also, hey, let's constrict our blood vessels. So angiotensin 2 can directly cause blood pressure increase to combat this low blood pressure by causing vasoconstriction. But it can also signal onto the adrenal gland. So hey, here's our adrenal gland. The kidneys, renals, this is the adrenal gland. Angiotensin 2 signaling on the adrenal gland will release aldosterone. So renin, angiotensin, aldosterone syndrome. So we have a renin, we have your angiotensin, now we have aldosterone. What aldosterone does is it signals to the nephron, specifically at the distal convoluted tubule. So this is important. Aldosterone signals at the distal convoluted tubule. It tells the distal convoluted tubule to absorb more sodium, absorb more salt. So it's going to absorb more of the sodium chloride. And that's going to happen is water will always follow sodium chloride. So what it's going to do is we absorb more sodium chloride, the water will follow. And as we absorb more water rather than pee it out, absorbing more water can help increase the volume in the blood vessels. Increasing volume in the blood vessels will help increase the pressure in the blood vessels. This is the renin-angiotensin aldosterone system. Blood pressure falls, juxtaglomerular cells, these different juxtaglomerular renal arterioles will release the renin. That renin is going to cleave angiotensinogen into angiotensin 1. ACE is going to convert angiotensin 1 to angiotensin 2. Angiotensin 2 can either signal to the adrenal cortex to release aldosterone or cause blood pressure to rise itself. Angiotensin 2 actually makes you crave salty things as well. So that's another way that we can try to increase blood pressure. Couple questions. So aldosterone tells the distal convoluted tubule to retain more sodium so that more water can flow in and increase blood pressure. Exactly. So aldosterone signals to the distal convoluted tubule to say, hey, let's absorb more sodium so that water can follow. We'll talk more about absorption in the kidneys here in a few slides. This is kind of a little bit of a sneak peek. Okay. And so, yeah, these guys are floating around in the bloodstream, waiting for their guys to go. And so ACE is one of those things that you could test in a blood test. Certain diseases will increase ACE, not necessarily blood pressure diseases, but this is something, it's throughout the body. It's in the bloodstream. You can detect it in the blood. If you have issues with high blood pressure, you can have ACE inhibitors, which will block these guys. You have ACE inhibitors, then you can't create angiotensin 2. And if you can't create angiotensin 2, you can't raise the blood pressure. So there's a way that we can prevent blood pressure from rising. Let's see. Is it only angiotensin 2 that triggers the blood pressure increase? Yeah, so angiotensin 2 is the one that creates that blood pressure increase, not the angiotensin 1. Just focus on angiotensin 2 and aldosterone here. So aldosterone is one that you really need to know, and specifically where it signals. So where does aldosterone signal? Distal convoluted tubule. And I'll kind of repeat that here in a few slides. There's a very similar hormone that gets produced in the hypothalamus and stored in the pituitary. We'll talk more about it in the endocrine lecture. But this hormone is called ADH, or anti-diuretic hormones. Diuretics make you pee. Anti-diuretic hormone prevents you from shedding that water, prevents you from peeing out the water. And so why would you want to do that? Because we want to keep that water so that we can increase the blood volume and thus increase blood pressure. So we can also release ADH if blood pressure is too low so that we absorb more water. And how do we absorb more water there? ADH signals to the collecting ducts. And so we'll talk more about the collecting ducts here shortly. And it tells them to absorb more water directly. We have aquaporins that line the collecting duct. ADH will signal to the collecting duct to absorb more water so that we can increase blood pressure. So in blood pressure regulation, we do have that aldosterone, we do have the ADH. They do similar things via different pathways, but where they signal is important. Aldosterone signals distal convoluted tubule, ADH signals at the collecting duct. If these blood pressures are too high, we don't have a reverse process here. We just stop secreting these hormones. We stop the signaling pathway. ADH is also nicknamed vasopressin, correct? And that is also another one. Isn't alcohol an antagonist of ADH? Absolutely. So if you ever drink alcohol, if you ever realized, hey, you really have to pee. The reason why is because alcohol inhibits ADH secretion. And so we're not releasing ADH to the body, and it's going to make us pee. So if you ever drink alcohol, you realize, wow, I really have to urinate. That is because we are suppressing ADH, and we'll talk about ADH a little bit more during the endocrine lecture. So osmoregulation. So we just talked about blood pressure regulation, osmoregulation. So what the kidneys do is they really dictate, what's being peed out and what's being reabsorbed. And so we're going to start reabsorbing things, and we'll talk more about the process of how it does that, and the proximal convoluted tubule and the distal convoluted tubule, and then eventually the collecting duct, how much water we absorb versus not absorb. And so the osmoregulation, how much solute is dissolved in the blood, can be altered by the kidneys. If we want less solutes in the blood, we'll just pee it out. If we want more solute in the blood, we'll just reabsorb it at the kidney level and not pee it out. So aldosterone increases blood osmolarity as well, right? Because we're going to reabsorb the sodium chloride back into the blood supply so the water follows and we can increase plasma volume. All right. We'll talk more about the secretion and absorption here in a little bit more detail. But it also affects acid-base balance. So one of these things that we can either absorb or pee out is bicarb. So if we have decided to pee out bicarbonate. If we pee out bicarbonate, we're peeing out a basic substance. So if we pee out all this bicarb, we can make our blood more acidic. If our blood is too acidic, rather than pee out the bicarb, we can choose to reabsorb it. So the kidneys can play a role in acid-base balance in either deciding to pee out or reabsorb bicarb. And lastly, in homeostasis, it helps with the removal of soluble nitrogenous waste. So any endogenous proteins that you make, any exogenous proteins that you eat, it's going to undergo proteolysis in the liver, and you're going to create a byproduct of urea. So urea will be utilized by some of your gut bacteria, but 90% of that is excreted in the urine. And urea is what gives the urine that yellow color. So urea is a toxic substance. We don't want to build up of it too much. So what we're going to do is we're going to pee it out, and that's what gives urine your yellow color. Alrighty. We have 30 minutes or so to go over probably the hardest part of the kidney lecture, second to the renin-angiotensin-aldosterone pathway. So the formation of urine. Here's a couple questions. So is that why when drinking more water, pee is less? When you drink more water, pee is more water. Oh, less yellow. Okay. Less yellow, I mean. Yeah, it's less yellow because we don't want a lot of that water. We'll go into formation of urine real quick. We'll talk about it a little bit more here. But rather than reabsorb that water, because we have so much, and we have such dilute solute levels in the blood, rather than reabsorb or rather than pee out the solutes, rather than reabsorb with the water, we're going to pee out less solute, pee out more water. So that's why when you're super, super hydrated, drink a lot of water, your urine becomes clear. So let's see. If your pee is clear, does that mean you're avoiding the production of urea in a good way? No, it's more of we're just diluting the heck out of that urea. When they check for protein in the urine, are they looking for urea levels or are they checking for straight up protein? Fantastic question. When we check for protein we're going to circle back around to my favorite protein. When we check for protein levels in the urine, we're actually looking at a lot of times albumin. We're talking about glomerular filtration here shortly, but protein in the blood, one of the ones they look at creatinine, which is a breakdown product, but they also look at albumin. So if you have damaged your kidneys, you will have a lot of albumin in your urine, which is not good. We don't want that. So how would we get albumin in the urine? Fantastic question. So glomerular filtration. So powered by hydrostatic pressure. So what the heck is hydrostatic pressure? Well, we have these blood vessels that are flowing all this blood in. You have all this liquid that's being shoved into this glomerulus. This glomerulus are all these very permeable capillary type vessels that are kind of bunched up. And so what's happening is we have all this blood flowing in, it has to travel throughout the glomerulus and it travels out. As it's traveling in, you have all this blood rushing in, it's putting pressure on the walls. Putting pressure on the walls of this glomerulus. So what's happening as we have this hydrostatic pressure, the pressure that is caused by the flowing blood pressing against these capillary walls, it's going to push out anything that is small enough to fit through the fenestrations in these capillaries. So these capillaries have little holes in them. The glomerulus has holes in them that are of a certain size. Anything that can fit through will be excreted through it. So it's going to filter out good stuff, some nice different ions that we want. It can, filter out, glucose. That's good stuff. We want glucose in our blood. It can also filter out bad stuff, urea, creatinine, um, sometimes albumin if it's damaged enough. What do I mean by damaged enough? So these holes are of a certain size in this glomerulus. Let's say over time, you have fit these different substances, whether good or bad, that are just a little bit too big for these holes. Maybe a protein that's just a little bit too big. But over time, it has been squeezed through these holes. If the more that these different gaps and openings are used, they kind of get stretched out. So if you have a lot of stuff that's dissolved in your blood, you can stretch out these holes. And what's going to happen is these things that shouldn't be filtered out, these bigger proteins, this albumin, right? Things that shouldn't be filtered out are getting filtered out because these holes have expanded. So this is where you get into chronic kidney disease. When you have to go into the realms of dialysis to filter out your blood, you've damaged your kidney glomeruli just because you have too many things dissolved. So what can cause this? Well, diabetes is one of these things that can cause it, diabetic nephropathy, where you have so much glucose, which is a rather big molecule compared to, things like sodium, things like chloride. Repeatedly, chronically filtering out so much glucose can damage your glomerulus. If you have a chronically high blood pressure, you're putting so much hydrostatic pressure on your glomerulus, you could stretch it out as well. You can damage your glomerulus. And so things like if you have, a poor diet, or maybe, hey, you have way too much calcium in your diet. Calcium can also, it's one of those things that's dissolved in your blood and it has to filter it out. Having too much being filtered out by your glomerulus can damage it. So things that are most common that can do that, are, diabetes, where you have too much glucose, or which would be uncontrolled diabetes, or, chronic hypertension, high blood pressure can damage it as well. So the question, all these dissolved ions and molecules in the blood or filtrate. So that is a great question. So they're all in the blood. All these dissolved molecules, their ions are in the blood, but as it goes through the glomerulus, it's going to be filtered out and it will become part of the filtrate. Anything that leaves the glomerulus and enters into the nephron becomes filtrate. So the rate at which we do filter out the blood is called the glomerular filtration rate, or the GFR. So we don't need to calculate GFR, thank gosh. We don't need to actually look at a number and say, oh, this is high, this is low. What does that mean? But we just need to know, when would we want to increase versus decrease GFR? If we have a very low solute concentration, low osmolarity, we might want to decrease GFR. We might want to decrease the rate at which we shuttle things out into the filtrate. If we have a very high osmolarity in the blood, we might want to increase the GFR. We might want to speed up the rate at which we shoot things out into the filtrate to filter that out. So we can increase and decrease GFR on a very, acute and rapid level. And the way we do that is by constricting or dilating the afferent and efferent vessels that supply the glomerulus. So we have a little bit of a mnemonic here. If I want to decrease the GFR, decrease the rate at which things are being filtered out, I'm going to want to decrease the hydrostatic pressure in the glomerulus. So how would I want to decrease the hydrostatic pressure in the glomerulus? Well, I'd want to constrict this vessel, constrict the vessel that is supplying the glomerulus, and dilate the vessel that is taking the blood away. So if we limit what's coming in, but don't limit what's coming out, we can actually drop the pressure because little's coming out, little's coming in, a lot is coming out. So mnemonic for this is CADE. CADE always acts to decrease the GFR. If we constrict the afferent, its afferent is traveling towards the glomerulus, it's being accepted, afferent. If we constrict the afferent vessel, but dilate the efferent, if we dilate the one that is exiting the glomerulus, we can decrease the GFR. If we want to increase the GFR, we can do the opposite. We can constrict the efferent, constrict this one, let less blood out, but dilate the afferent. If we want to dilate the afferent, more blood will come in. If we constrict the efferent, less will get out. If more's coming in and less is getting out, then we're going to build up pressure. We're going to build up hydrostatic pressure. We're going to start shooting more things out to the filtrate in any given time. There's a question. Why do we have decrease in GFR when we constrict the efferent arteries? We increase GFR when we do that. I thought we have to decrease the diameter. No, it's essentially you're creating more resistance. That's what's going on here. Yeah, so what we're doing is we're playing a role in resistances. So if we want to decrease the GFR, we want to decrease the pressures in here. So what we're going to do is we're going to increase the resistance in this vessel. So we're going to constrict the afferent one. So CADE always acts to decrease the GFR. We're going to constrict the afferent. So the vessel coming towards it, we're going to constrict it, create more resistance. If we're going to create more resistance, blood is going to be shunted into other directions. Less blood will be traveling in. So essentially we're working with shunting here by increasing the resistance. But we're also going to decrease the efferent. So if we decrease the efferent, more blood can travel out, there's less pressure. So to decrease the GFR, we're going to decrease the pressure in the glomerulus by constricting the afferent vessels, dilating the efferent. And we could do the opposite to increase. If we constrict the efferent, we're going to increase the resistance in this vessel, creating this backlog, and we're going to dilate the afferent. So more can come in. We're going to create more of a backlog, more buildup of hydrostatic pressure, more stuff will be filtered out. A couple questions. The first one is, this is kind of random, but is hydrostatic pressure always from the blood to the tissue? And osmotic goes from tissue to blood, or there is some, it's not always in that direction. Let's see, I'm trying to reword your question. So it's essentially hydrostatic pressure is liquid to tissue. So there is some sort of, because there is some liquid, there is some fluid in this capsule, there is a hydrostatic pressure pushing back on it, but the net hydrostatic pressure is from the vessels outwards. So it does come from the blood. The net increase in pressure is coming from the blood outwards. And yes, osmotic pressure goes from, not always from tissue to blood. It really depends on what the solute concentrations are in that liquid. So in this case, we're in the kidneys. This blood hasn't been filtered yet. So there is a higher osmotic pressure, essentially hydrostatic pressure, and then this is being filtered out in the Bowman's capsule. Let me reword that. There's Bowman's capsule. There's so much filtrate in here that there is going to be some sort of osmotic pressure pushing back. But then again, you have to think, you've taken osmotic pressure into account, you have to take hydrostatic pressure into account. The hydrostatic pressure of this blood vessel coming in on net is creating a net increase in pressure. So more stuff is going to push out than push in. Just to kind of simplify it for yourself, just think hydrostatic pressure is going to overcompensate for all these other pressures playing a role. And the net change is you're shooting stuff out into the glomerulus. And so that's what's important. The net change is you're shooting stuff out into the glomerulus. We're confused on how decrease in diameter doesn't mean increase in blood velocity. Yeah, so typically if you just had one blood vessel and if you had one nephron and one kidney, only one organ, a decrease in diameter would increase velocity. That's something, you're right. But we do have more blood vessels throughout the body. We have more organs. We have more nephrons. Constricting a blood vessel here it will increase velocity on a very acute short-term level, but it'll increase resistance quite heavily. If we increase resistance, blood's going to follow the path of least resistance. So essentially, we're going to be shunting blood away. So blood's going to go other places instead. So in this case, if we want to decrease the cross-sectional area here, it will at a time cause an increase in velocity in the blood that is at this area, but less blood can travel through that little opening that is constricted, and there's going to be more resistance. There's going to be a little backlog. If we constrict up here, that backlog will shunt blood elsewhere. And so there's the law of continuity will play a role on a very acute level, but there's so many other things coming in to play that you can't say that constricting this will cause a velocity that will decrease the pressure. We're talking more, this is more looking at resistances here because there's so many other vessels in the body. More than one vessel thing again. Yeah, so let's say we have blood going to the kidney and blood going to a muscle. If we constrict the blood vessels going to the kidney, you're essentially going to cause shunting. The blood's going is like, ooh, gosh, there's resistance there. I don't want to go to resistance. I'm going to follow the path of least resistance. So rather, it'll travel to the muscle. And let's say we aren't working out, so we don't need blood going to the muscle. We can constrict the vessel going to the muscle, create more resistance, and I'll instead send it to the kidneys. So essentially what's called shunting. We can constrict some vessels to send it to other places in the body, and that's called shunting. So the law of continuity is going from one vessel to another, like we're working in the same vessel that is changing diameters. But the path of least resistance is more of a systemic thing where we're taking in multiple pathways that's going on. So you can look at it, if there's only one path for it to go, law of continuity will play a role. But if there's more than one path, then you need to look at the path of least resistance and how Poussin's law plays a role in that resistance. That makes sense? Yeah, awesome. Okay, so secretion and reabsorption of solutes. So when we do filter out everything, right, the good, the bad, what are we going to do with all that good? We don't want to get rid of it. We don't want to waste all that glucose that we just spent, energy to obtain. We had to find the food. Like, we don't want to just get rid of the glucose all willy-nilly. There's some nutrients and different ions that we still want. So what's going to happen is most of the reabsorption. So if we're in the filtrate, this is again tube within a tube system. If you're in the kidney itself, in the cortex, in the medulla, you're technically in the body. But if you're inside the nephron, inside this tube, you're outside of the body. So kind of orientation again, if you're inside this blue area, inside this nephron, you're technically outside of the body. So if you're secreting things into this nephron, you're secreting them out. But if you're bringing them back into the renal cortex, into the renal medulla, you're absorbing it back into the body. So at the proximal convoluted tubule, you'll get majority of your reabsorption. All that glucose, all the good stuff you still want, you'll bring it back into the body. You're going to reabsorb it back into the cortex. So most of your absorption, if you see a passage and you think of, if it's not asking for a specific, hey, NaCl or sodium, it's asking where would glucose most likely be absorbed, choose proximal convoluted tubule. Most things are going to be reabsorbed in the proximal convoluted tubule. At the distal convoluted tubule, which is again over here, you still have some minor reabsorption going on. But when you see this in a passage, what would most likely be absorbed in the distal convoluted tubule? Sodium chloride, right? The sodium chloride from the aldosterone signaling. And if you're absorbing the sodium chloride because of the aldosterone signaling, water will be absorbed as well. So when we talk about reabsorption, this is the location at which the aldosterone functions. ADH functions at the at the collecting duct level. We're going to absorb more water here, and we'll get into collecting duct at the end here. But Yeah, so absorption, bringing it back into the cortex, back into the medulla. Secretion is into that filtrate into the nephron itself. There's a question. So secretion into the nephron is exocrine, but into the renal cortex is endocrine. In a way, yes, but endocrine and exocrine is essentially, when you see that for biology, you'll see that more in the context of hormones. But in terms of directionality, yeah, back into the nephron would essentially be exocrine. But it's not really signaling either. It's just we're filtering it out. Anything in the inside the nephron is filtrate. It is essentially for directionality. Yeah, it would be exocrine. So when things are absorbed at the proximal convoluted tubule, are they still considered outside of the body? Okay, yeah. So that's a great question. So if we absorb things at the proximal convoluted tubule, so we have absorbed things back in, are they still considered outside of the body? No, they're not. So if we're inside the cortex, if we're inside the medulla, that is considered back inside the body for directionality purposes. How do they get back in? So once we're in this area, if we actually go back, how does it get back into the blood supply? Everything here is being lined by these blood vessels. And so while it's back into the the renal cortex, the renal medulla, it is it's an interstitial space at that point. Interstitial spaces are still considered in the body. How does it get back into blood circulation? It's these vessels. They're going to absorb back into these vessels. They're going to pass through them. The vasa recta is actually the correct term for it, but it will diffuse back into the vessels. Yeah. So we're in this is all interstitial spaces. Interstitial spaces exist throughout the body. They're still part of the body. How does it get back into blood circulation? How does that glucose get back in? Is those blood vessels that line each nephron. And just think, there are millions of nephrons. It's not just one guy sticking out here. They are stacked upon each other. There's vessels upon vessels. It's so vascular in there that it will just be reabsorbed back into the blood. Okay. So we reabsorb at 3 locations: proximal convoluted tubule, distal convoluted tubule, and the collecting duct. So yeah, most things back at the the proximal convoluted tubule. So one thing that we want to do in the kidneys is filter out the bad stuff, but reabsorb water, create urine. As we create urine, we can get rid of waste and we can reabsorb water. And where kind of the magic happens in urine creation is the loop of Henle. So this is going to get a little bit abstract. These next 2 slides are going to be as conceptual as we get today. For urine creation, we want to create a filtrate that has urea in it, has waste in it, and we want to absorb water at the collecting duct so that we could pull water back into the body and just get rid of that waste being that urine. So I'm going to flip these slides around real quick. So concentration of urine. When we have this filtrate that passes through the kidneys, at the very end is where urine concentration occurs, at the collecting duct level. And the way this works is we have this filtrate that has a lot of all our wastes and a lot of water. So our osmolarity up here in this filtrate is very low. It's very, very dilute. There's a lot of water here. And so what happens is as we go through the collecting duct, we are reabsorbing more and more water. And the way we absorb more and more water is this osmolarity that exists in the interstitial spaces. So the adrenal medulla at the very center is very, very salty. It's very, very high osmolarity, 1,200 milliosmoles per liter. So what's going to happen is as we travel through the collecting duct, the filtrate in the collecting duct is going to try to balance out this osmolarity. And the collecting ducts are lined with aquaporins, water channels. So what's going to happen as we travel through this collecting duct that is only being, permeable to that water is going to try to flow back into the interstitial space, balance out the osmolarity between the medulla and the filtrate, and in the very end, create a very concentrated urine. So the filtrate becomes very concentrated because the collecting duct, we try to match this osmolarity gradient. So how exactly do we measure that gradient is the countercurrent multiplier mechanism, which I'll talk about next slide. But let's say we have ADH. If ADH is present, what it's going to do is it's going to open up more aquaporins. So the ADH works at the collecting duct level. And if we open up more and more aquaporins, we can absorb more and more water. So if we're absorbing more water, we're not peeing out the water. But to create this concentration gradient, to even concentrate the urine through the collecting duct, we need the countercurrent multiplier mechanism. So this is something that occurs at the loop of Henle level. So at the loop of Henle, you have this thing called the countercurrent multiplier mechanism. Why is it called that? It's because down the descending loop of Henle, you're going one direction down, and then you're going up the loop of Henle. So you're going countercurrent going opposite directions, multiplier mechanism. And that's because the longer the loop of Henle, the more concentrated you can make this gradient. The longer the loop of Henle, the more sodium chloride pumps you could put on the ascending limb, the more concentrated you can make this osmolarity gradient, and thus the more water you can hold on to. The camels, the animal camels, have very, very long loops of Henle. Because they have these long loops of Henle, they can create these massive concentration gradients. So as the filtrate goes down the collecting duct, this massive concentration gradient will create a very, very concentrated filtrate, very concentrated urine, and you'll be able to hold on to more water because they can make their urine more concentrated due to their extremely large loops of Henle. So how exactly does this even work? How does this create that concentration gradient? So this is a little bit on a conceptual level, a little bit confusing at first. So let's pretend this is a brand new kidney, brand new nephron, never has seen any filtrate before. Everything is the same concentration. There is no difference in osmolarity throughout this nephron. As the filtrate gets formed, it's just traveling. We're at 300. This would essentially be 300 as well. This would be 300 as well. 300, 300, 300. Nothing's happened yet. This is a brand new nephron. Nothing's happened. You're going to have no passing of any substance, any liquid, any ions. You'll be reabsorbing some stuff here, some of the glucose and whatnot. But in terms of if we're looking specifically at salt, the concentration will be the same. As we get up to the ascending limb of the loop of Henle, we're going to start absorbing, active transport, absorbing more sodium chloride. By absorbing, we're taking it from the nephron and we're shuttling it into the interstitial space. As we shuttle it into the interstitial space, the aquaporins on the descending limb will try to balance that out. And so if we're extracting water from the nephron here, it's going to start to concentrate. It's going to start to concentrate the filtrate. So as we get here, we have very concentrated filtrate, and we're going to continue to shuttle out sodium chloride. We're going to continue to shuttle it out, and we're going to continue to have aquaporins, the water follow. So as we're doing that, we're extracting water from the filtrate, concentrating it here, and we're having now passive, where if we have caused so much water to flow out, we have passive flowing out of the sodium chloride as well. And these guys continue to work. So the longer you have this loop of Henle, the more sodium chloride channels you can put on the ascending limb. The more sodium chloride channels you can put out, the more sodium chloride you can shove into the interstitial spaces, create a very salty environment in this area. And so the inner medulla, the interstitial space, is going to start to balance out with the bottom of the loop of Henle, balance out in osmolarity. So this loop of Henle has created a very concentrated filtrate now we have open channels of sodium chloride, open channels of water. We're going to try to balance out this gradient here in the interstitial space. And that's going to be true throughout all of the kidney because we have millions of nephrons. We have millions of these guys doing the same thing. They're all working together to create this gradient here. So this interstitial space is not just from this one nephron, it's from all 1 million of these nephrons. So as it comes, we have the distal convoluted tubule. We haven't excreted urea at this point. We still have some sodium chloride in here. So what's going to happen as we get to the top of the collecting duct and we travel down to the collecting duct into the renal pelvis, into the ureter. So as we go down the collecting duct, all these aquaporins that align the collecting duct are going to be open, and the water and the filtrate is going to try to balance out with the salty interstitial fluid. And so as it balances out and we're extracting that water, we're bringing the water back in, we're creating this very, very concentrated urine. So the urine will be more yellow. So if, let's say, we are super, super hydrated, this filtrate isn't going to be as dilute, or it's not going to be as concentrated. It'll be even more dilute than this. We'll have less sodium to shuttle out. We'll just have more water. And if we have less sodium available to shuttle out, we're going to create a more dilute interstitial space. And if we have a dilute interstitial space, we can't concentrate the urine at the very end because the water won't be able to get as concentrated here at the very bottom. So that's why our urine becomes more light. It becomes more watery because if we're super, super hydrated, we have a hard time generating this concentration gradient. At just homeostasis, our concentration gradient looks more like this. And so as we travel down the collecting duct, we create more concentrated urine. So as we travel through the collecting duct, we meet in the renal pelvis, we travel throughout the ureter, and the ureter drains into the bladder. And so at the bladder level, it'll be stored until we're ready to go. Your brain gets signals from the bladder being distended, saying that, hey, I'm going to pop. I'm going to urinate myself at about 30% of capacity. So you can actually hold more. You're not going to actually pop, but your brain, as a reflex, gets signals from the bladder saying, hey, we got to go, when it's really not that full. So yeah, that is it for renal system. Countercurrent multiplier mechanisms is quite complicated topic. Definitely recommend watch videos on that. There's a specific video. There's a video channel. You might actually find it useful for more things than just renals. It's called Ninja Nerd, I think is what's called, lectures. I just typed the name in the chat. Check out their video if the countercurrent multiplier mechanism did not make sense. It can help with a lot of different biochemistry type things as well. The countercurrent multiplier mechanism, what happens is the loop of Henle itself generates that osmotic gradient in the interstitial space so that we can concentrate the urine in the collecting duct. Any questions? Oh, you already found it. Very nice. The YouTube link is in the chat. Thank you, Jonathan. Any questions on that right now before we get into some passages? If you don't want to stay for the passages, you are free to go. Enjoy your weekend. I'll see you guys next week. If you guys do want to stay, we'll go over the passages right now after we answer any questions that we might have. Y'all good? The biggest slides of this lecture are countercurrent multiplier mechanism. Kind of combine it with this slide right here. These two slides, renin-angiotensin-aldosterone system. Where did that go? Here, that is huge. Yeah, I mean, these are probably the two most important slides of this lecture. Slides 30 and 38. All right, if you have no questions as of right now, give you a couple minutes to read this and answer this question. So these ones, I get a lot more split in answers. A lot of people disagree with these. We'll go through them together once we get people answering in the chat.
Hey guys, can you hear me? This is Josh. Um, so I got an announcement for tomorrow. I actually just got off the phone with Diego, um, and unfortunately, his grandmother just recently passed, which is really unfortunate. But he said that he wanted me to let you guys know that he won't be actually able to make tomorrow's morning. So I wanted to, tell you guys and then give you guys a couple of options um, of what we can do for tomorrow. So tomorrow we can either start sociology and go over social demographics tomorrow at 9 a.m. Or if you guys, feel like you could use a day off and just reschedule, Diego's lecture down the road, then we can do that. I know tomorrow's Halloween. I know maybe some of you might like that. But regardless, I think, let me know. Yeah. And so tomorrow I would be doing this social demographics lecture and then getting Diego to switch with me and do that in 2.5 weeks when I was going to do it. And if you guys want the day off, we could do that. So just, let's do a vote, I guess, in the chat for now, and then I'll, obviously email everybody. What changes will be adjusted in the schedule if we were to incorporate social? Most likely we would just switch the sociology, the social demographics lecture. That's I can't share my screen now, but if you go into the schedule, it is on November 17th. most likely switch tomorrow's lecture for November 17th. Would be probably the easiest thing we could do. You know, so you guys want to do the schedule switch? Okay. And how many people want to cancel? Social demographics is just going to be an introduction to sociology, where we're going to go over, you know, the demographics of, you know, society, and how they pertain to the MCAT. So Tiffany, what do you mean switch? So literally switch Diego's lecture tomorrow with the social demographics lecture on November 17th. And I will be teaching tomorrow if you guys want me to teach tomorrow. Yeah. Okay. I'd rather stay on schedule. Okay, cool. Well, then tomorrow morning I'll do social demographics. And then if for anybody who wants to take the day off tomorrow, we can schedule an office hours, do social demographics again to go through tomorrow. We're going to go through slides. Tomorrow's actually lecture is pretty, it's pretty straightforward, you know, but it's a good intro into sociology and into, you know, starting to get thinking like that. Social demographics, it's a sociology concept, right? It's a section of sociology that's pertinent to the MCAT. Okay. And no, there is no reading, but we're going to talk about the sociology vocabulary, you know, and cover all that, you know, what you need to start looking into for sociology. You don't need to prepare at all for this lecture. This lecture is very straightforward. You can just show up. Yeah, Diego, unfortunately, he called me, you know, just an hour ago, and his grandmother actually just passed, and they actually have to transport her back to Mexico. And he speaks the best English in his family, so he's going to have to, you know, take care of family issues. Yeah, it's a bummer, but you know, you got to do what you got to do. You don't need to prepare for the sociology lecture at all. You know, just show up and we'll talk about sociology and sociology on the MCAT. And so I guess we'll see you guys tomorrow at 9 a.m. If anybody wants to take the day off tomorrow, that's fine. Just let me know that you do, and then we can talk about sociology at a different point. Yeah. And we can go over tomorrow morning about what resources you should look at for sociology on the MCAT. Okay. And yeah, if any of you guys have any questions, I'll stay here until Spencer's done with his slides, but I don't want to hijack his lecture right now. Okay. So I'll just mute myself.
All righty. So back to this question. A lot of you guys got it. A couple comments on this. Sounds like a completely foreign language, and that is bio. Bio, absolutely, for the MCAT. You can be a bio major, and a lot of their passages will sound like a foreign language. They just like to bog you down in jargon. So the good thing is when you're starting to prepare, the more practice tests you do, the more practice passages you could do, you can learn to pick out what's important and learn to kind of reword things in your own head. So for me, you know, when I started to, I guess, reword things and make things more, I guess, basic in my head, I was starting able to see things more clearly, able to think more straight. When you see things that are bogged down with jargon, you start to stress out, you get lost, and you can make more mistakes. And so for this passage, let's go through the passage real quick, considering its involvement in blood pressure regulation. Okay, so the kidney has interested scientists hoping to treat drug-resistant hypertension. So blood pressure that can't be treated with medications. So one technique researchers have started to explore is the denervation of the renal artery. So taking the nerve off the renal artery, so you're going to get no nervous signaling from that artery. To do this, the nerves in the renal artery that relay signals from the autonomic nervous system are removed. So in my head, I kind of crossed that out. It's like, okay, that's pretty much what denervation is. This is thought to improve blood pressure. Okay, so that's what we're trying to do. The enzyme renin, we talked about the renin-angiotensin-aldosterone system, is secreted by kidney arterioles. So it tells us what type of cells release the renin in response to a decrease in arterial blood pressure. So these kidney arterioles will release this renin due to a decrease in the arterial blood pressure. So a nephrologist, a guy who studies the kidneys, is interested in studying the safety of this procedure and measure the serum levels of renin in 200 mice. The results are shown below. Serum levels are in a blood test, a lab test. You took out the blood and we measured the renin levels in the serum, in the blood. Okay, so a lot of people got this. So usually the answers I get are between A and B, but a lot of them are overwhelmingly B today. So let's go through this. So based on the response in mice with denervation in figure 1, what can be concluded about renin secretion? So when they say, we see passages that say based on the response of mice with denervation in figure 1, only choose things that you can be deduced from figure 1. So a lot of these types of questions will have a true statement hidden in the answers, but it's not something that you can deduce from the figure. So let's go through this. A, it is entirely controlled by neuronal signals. So let's look at the passage, let's look at the figure. So on the left here on the y-axis, we have renin concentration over hours, and the two groups are without denervation, so basically with the nerve, and then a group without the nerve. The group without the nerve has lower levels of renin. And so it's like, okay, so there is some renin secretion is controlled by neuronal signals to some extent. We know that. B, it is mediated by barometric and chemical signals. Okay. There's nothing here that says that is wrong. C is it is responsible for the cleavage of angiotensinogen into angiotensin 1. So renin, if we recall the renin-angiotensin-aldosterone pathway, renin does cleave angiotensinogen into angiotensin 1. But you can't deduce that based on figure 1. So C is that true statement that is hidden in here, that you cannot be based on figure 1. And then D, it is dependent on the presence of prostaglandins. We didn't even learn what prostaglandins are. That's one of those things that's just in there, just to be in there. So the answer for this one is B. So why is it B versus A? So while there are neuronal signals that do play a role, we have a lower renin concentration with denervation, but there are still fluctuating levels of renin concentration. You're still getting the fluctuation of the renin. It's increasing, and even at baseline, these renin levels aren't at 0. They're still a non-zero number on this y-axis. So because it is still fluctuating, it's still a net increase over these hours and not at 0, you cannot say that it is entirely controlled by neuronal signals. So it cannot be A, because you cannot deduce based on the data given that is entirely controlled by neuronal signals. If it was entirely controlled by neuronal signals, this would be just a flat line at the bottom. Yeah, so you're able to highlight in the passage with the computer. Barometric means pressure. So there are barometric signals. Real quick, right? If we have a low blood pressure, that's going to signal the release. So barometric is pressure, and then chemical signals is hormonal or whatnot. And so, yeah, so they're not just by neuronal. So just by saying, by deducing that even without the neuronal signaling, you're still getting fluctuation, you could say A is not true. So process of elimination. And you can highlight during the passage on the top right corner, I believe it is. There's a little highlighting tool. And so what I do is I reword things in my head every single time. Every passage, every question, I try to reword things in my head to eliminate jargon and to make it a little bit more straightforward for myself. And so Renin is secreted by these types of cells. So that type of cell is a kidney arteriole in the response of just low blood pressure. So I'm just going to decrease the jargon as much as possible. And we'll see that as we keep going. Next question, which of the following contains cells that are most like the cells that secrete renin in the kidney? It's about a minute to answer this one. Alrighty. All right. So you guys wanted to choose C, but you guys are sketched out by C. So what type of cells, are most like the cells that secrete renin? So which of the following organs or structures contain cells that are most like the cells that secrete renin? So the key is here, what type of cells secrete renin? So we didn't say that in lecture, but the answer, the information is actually given in the passage. So the enzyme renin is secreted by kidney arterioles. So which of the following structures has cells that are most like that of arterioles? Right? So if you look at A, bicep's a muscle. So is a muscle cell going to be similar to blood vessel cells? No. B, left ventricle. Oh, so that's cardiovascular, right? It's the heart. But the heart itself is a muscle. So again, no, arteriole is not going to be like the muscle. The nephron. Okay, that's okay. We're at the kidneys. We're at the kidneys. That might be a little bit more of a tantalizing answer, which a lot of you guys put. And then radial artery. So radial I see is confusing some people. The radial artery is the artery that travels next to your radius. So if you stick your hand out and check your pulse next to your thumb at your wrist level, that pulse that you're feeling at your wrist on the side of your thumb, that is your radial artery. So it's just the location. So is an arteriole similar to an artery? Absolutely. It's just smaller than an artery. A nephron is, epithelial cells, cuboidal epithelial, that doesn't matter, right? It's more of on that case, we're shuttling sodium across, we're reabsorbing some ions. An arteriole is more like an artery than it would be a nephron. And so if you're looking at functionality, so functionality, an arteriole is still more similar to an artery. If you're looking at location-wise, yeah, kidney arteriole is similar to a nephron because, kidney arteriole is on the posterior side, just underneath your rib cage. And then your radial artery is at your wrist, is at the radius in your arm. So even functionality-wise, arterioles are more similar to arteries than they are to nephrons. Radial is blood vessels from the heart, not necessarily. You have a radial vein as well. So you're talking, it's not far from the heart. So there's difference. So you're thinking distal versus proximal. Proximal is close to the heart, distal is far from the heart. Radial is a specific artery or vein that is next to a bone in your forearm called the radius, right? In the forearm, you have the radius and the ulna, right? So the artery that is against the radius, which if you stick out your hand, right, and you keep your thumb up, give a thumbs up, the bone on top of your forearm, which you're touching, that is your radius. And so the artery, the radial artery, is that artery. So you're thinking of proximal versus distal. Distal is far from the heart. Proximal is next to the heart. So yeah, for this one, a lot of people like to choose C because they think kidney arterial versus nephron when they don't compare arterial versus artery. And caught up in that jargon. Okay, which hormone or protein will likely be present in similar levels in both groups of mice shown in figure 1? So reword this question. What is it really asking for? All right, it looks like we got that. I think, Sophie, you tried to reword the question. You can actually even reword it to make it more simple. So it's asking which hormone or protein will likely be present in similar levels in both groups, shown in figure 1. So yeah, so the difference between both groups is innervation versus denervation. But really, the question you can boil it down to is what hormone or protein would be present in similar levels with differing concentrations of renin. So what's different between the two groups is the concentration of renin. So you have to think which of these following, which of the concentrations here are independent of renin concentration. So you guys, a lot of you guys put C. It is C. So why? So if we have angiotensinogen, right? So if we have more renin, we will cleave all the angiotensinogen. So if we have more renin, we have less angiotensinogen. If we're cleaving that angiotensinogen, we're creating more angiotensin 1. And if we have angiotensin 1, we will be creating more angiotensin 2. So A, B, and C, they are all dependent on the concentrations of renin. C, as you said, angiotensin converting enzyme, ACE will be there. It's the RAS pathway is not creating, not destroying the ACE, the angiotensin converting enzyme. It's just there. It's sitting there floating, waiting for its substrate. That substrate is angiotensin 1. So more or less renin won't change the amounts of ACE. That is why it is C. Then last question. Which of the following hormones directly increases blood pressure independent of renin levels? Lovely. So a lot of people always get this one wrong too. This one's just a process of elimination. So again, which of the following can directly increase blood pressure independent on renin levels? So we can use different criteria to start eliminating some answers. So let's look at things that increase blood pressure. Does aldosterone increase blood pressure? Yes, it does. Does ACE increase blood pressure? Not directly. Right, it's just that enzyme. All it does is convert ACE, angiotensin 1 to angiotensin 2. Can angiotensin 2 increase blood pressure? Yes, it can. Right, it can cause vasoconstriction. And then D, cortisol. Well, we haven't learned too much about cortisol. So based on that criteria, we can get rid of B because B doesn't increase blood pressure. Now you have to look, okay, which of the following are independent of renin levels? Well, we know that aldosterone gets produced downstream of renin signaling, so it can't be A. Angiotensin 2, well, if we deemed last question that angiotensin 2 is not independent of renin levels either, so it can't be C. Because if we have more renin, we downstream create more angiotensin 2 as well. So we have eliminated A, B, and C based on those two criteria. We haven't learned much about cortisol. We'll talk about cortisol in the endocrine lecture, but it is a stress hormone and can directly cause increase in blood pressure. And it is not related to our renin angiotensin aldosterone pathway. So that's for this one, the answer is D. For those of you who did answer, got it right. And that is all for today. I will stay and answer questions after you guys figure out what you want with Josh. But otherwise, if you guys don't have any questions for him, don't have any questions for me, have a great rest of your weekend, and I will see you next Saturday. Yeah, I can go over that again. If I can get it to. So the glomerular filtration again. So it's basically what's going to happen is blood's flowing into the glomerulus. There's going to be a buildup of pressure, right? Because you have blood flow flowing in, and it's going to push on the walls of this vessel. It's going to push on the blood that's already been in there. So you're going to have this pressure of just flowing fluid, right? If you stick your hand in front of a hose, you can feel a pressure from that fluid hitting your hand. So there's going to be a pressure that exists on the walls of these vessels. That pressure that's on the walls of these vessels is going to push some of these dissolved solutes, the sodiums, the potassiums, right, the urea, glucose. It's going to push on these dissolved solutes. It's going to push them across this vessel wall, across the glomerulus wall, and into the filtrate. So you can really adjust the pressures. And by adjusting the pressures, you can adjust the rate at which it comes filtered out. So the way you can adjust these pressures is by constricting and or dilating these afferent and efferent vessels. So you can increase the pressure by constricting the efferent vessel, constricting the one that's leaving, creating more resistance in that vessel, and dilating the one that's afferent, that's coming in. So if you're allowing more blood in and increasing the resistance of the blood leaving, you're just going to jack up the pressure that exists inside that glomerulus. And that more pressure will push on those solutes even more and push them through the glomerulus and into the filtrate. Let's see. You respond. Assuming dilate at the top. So what we're actually dilating and constricting, when we move this bar thing, where we are dilating and constricting isn't at top versus bottom. There's smooth muscles in our blood vessels, right? Because there are these smooth muscles that exist around our vessels where we can constrict and dilate these guys. So this is our efferent vessel, right? Efferent is exiting the glomerulus. And this guy is our afferent vessel. It is being accepted by the glomerulus and it's going in. So by contracting or constricting or dilating these guys, we can adjust the pressures inside the glomerulus. That makes sense? Okay, let's see. I need to respond to a message, and then we're going to go over the multiplier mechanism one more time. One sec. Okay, so multiplier mechanism. I don't like this picture. I need to actually adjust that picture. Let me annotate clear all drawings. Okay. Enter some chats. We are all good. So the way what we want to do in the very end of urine formation is concentrate it. So the way we concentrate it is as the filtrate is passing through the collecting duct. This is the very end stage. The collecting duct is where all our hard work comes to pay off. And so the collecting duct is lined with these aquaporins that allow water through. And so as it's leaving through the collecting duct and being drained into the renal pelvis, it's going to, the water content of this filtrate, the stuff that's inside the nephron, is going to try to balance itself out with the osmolarity of the interstitial spaces in the kidneys. So how do we even generate this osmolarity gradient for the collecting duct to allow that water to pass through and concentrate what's in here? So we start very dilute, and as we extract more water, it becomes more concentrated. And what it's doing is this water is flowing out from a a low osmolarity to a high osmolarity. That is what's the inner medulla, this very salty environment, right? So how do we even create this salty environment? And that's the countercurrent multiplier mechanism at the loop of Henle. So what happens is, where this gets kind of funky, and this is why I recommended that Ninja Nerd video, because he has a whiteboard that he draws it out. What happens is, let's say this is already, what's pictured here is a nephron at homeostasis. Everything's already at the osmolarities where it needs to be. No, nothing acute is happening. You're not seeing any magic happening. So this, as I said, let's pretend this is a brand new kidney, brand new nephron. None of these other nephrons have generated any osmolarity gradient. Everything is the same osmolarity. Everything is dilute and uniform. As the glomerulus is filtering out that filtrate, we do have the filtrate that travel through. Nothing's happening, right? We have these open aquaporins, but at this case, because it's a brand new nephron, brand new kidney, there's no difference in the interstitial osmolarity and the filtrate osmolarity. So while these aquaporins are open, there's water's not going to flow one way or another because there's no difference in the osmolarity. So it'll be true throughout the descending limb. We get to the very bottom and we head up the ascending limb. Nothing's changed. Nothing's done anything yet. As we travel up the ascending limb, we hit these active transporters, these sodium chloride transporters on the thick part of the ascending limb. They start actively pumping out sodium chloride. So the longer the loop of Henle, the more sodium chloride you can actively pump out. So as we're pumping more and more out, we are diluting the filtrate. You're not pumping out the urea. So we're not pumping back in or reabsorbing any of this toxic stuff at this point. If that stuff is still inside the filtrate, but we are reabsorbing more of this sodium chloride. And because we're taking the salt out of the filtrate, it becomes more dilute. But the trade-off of this becoming more dilute is this interstitial space becomes a little bit more concentrated. So to counteract that, these aquaporins that are now open, they are going to take water, is going to flow through and try to balance out the sodium that is now in this space. So this sodium, yeah, it's flowing out this direction. The directionality of this diagram is kind of funky, but you do have a million or so nephrons doing this simultaneously in that same kidney. So all of these nephrons are pumping out this sodium chloride at the top of the ascending limb. And so this water in this descending limb is going to start flowing out to try to counteract that. As it counteracts that, because we're extracting water from the filtrate here, the filtrate becomes more and more concentrated. And these open aquaporins, these open channels, are going to balance out this interstitial space. The inner medulla, the outer medulla, they're going to try to balance out with what's inside the filtrate. So at the very bottom, we're at 1200, right? So as we go back up, we have a very concentrated filtrate, but we're going to continue to pump out the sodium chloride. So it's going to continually get more, it's going to get more concentrated because we're extracting water, and it's going to get more dilute as we're taking out the salt. That's inside the filtrate. But this interstitial space, because it is balancing out with what's going on in these loops of Henle, this interstitial space near the inner medulla. So if I go back and if I kind of go to a different diagram of the kidney. So we have all of these nephrons. So if we look at where the nephron is, it's right in here. So all of these nephrons are adding into the super salty environment in this inner medulla space. So as the collecting ducts are draining into this renal pelvis, the collecting ducts are going to reabsorb water to balance out this salty environment and thus concentrate the urine as it enters into the renal pelvis. So why is it called countercurrent multiplier mechanism? Is because you're going in opposite directions, right? This one's going down, it's going up, countercurrent. And then multiplier is because the longer the loop of Henle, the greater the concentration gradient you can produce, because you can fit more of these sodium chlorides channels, these active pumps, to reabsorb it. So that is where you get the multiplier mechanism, because it is multiplies with each additional sodium chloride channel that you can fit. Does that make sense? A little bit more sense? Definitely recommend the Ninja Nerd lecture. It helps you. Awesome. I'm glad. Yeah, it helps you kind of picture it more. This is definitely one of those visual things that just to see a brand new nephron functioning and how that works helps a ton. How do you know which ones are active and so pretty much what becomes active versus passive transport, even in, where is it? At this level, it's not too important. It is color-coded, active transports in red, passive transports in blue. Where it gets a little bit more important, so I wouldn't even recommend saying, oh, well, glucose reabsorption is active transport. That's not something that you might be asked, but more so conceptually, the active transports in red, passives in blue. The only place you have active transport in the loop of Henle are the sodium channels at the thick part of the ascending limb. So these guys, the fact that they're active and always pumping out sodium chloride, no matter the concentration, is what kind of gives the sodium chloride channels their gradient producing power. Because if these guys were passive, they wouldn't really extract sodium chloride up to the top of the ascending limb because it's so dilute up there. Why would you take out more sodium chloride? They need the active transport to actually pull it back in. Awesome. All right, any other questions? All right. I'll stay here just in case. Thank you guys. If you guys have any questions, actually, I'm gonna hand it over to, I'll go over that question real quick, then I'm gonna hand it over to Josh. Do you have any questions after this one? Feel free to email me. We could set up office hours. So, all good. Let's do the last questions on the renin-angiotensin system again. Where did that go? It was up. Nope. There it is. Okay. So small, can't see. So renin-angiotensin system. So what it does, this is a response to, this is a hormonal response to a low blood pressure. So that the trigger here, the stimulus is the blood pressure falls. So if we kind of relate it back to that passage, right? What noticed it? So it was the rate. It was the kidney arterioles, right? So the kidney arterioles realized, hey, the blood pressure here is low. So what they're going to do is they're going to release renin. As they release the renin, they're going to, that angiotensinogen is going to be cleaved by the renin, which is going to create the angiotensin 1. Angiotensin 1 will float around. It will find its enzyme, angiotensin converting enzyme, ACE. ACE is just looking for its substrate. It substrates the angiotensin 1. So ACE is going to convert the angiotensin 1 into angiotensin 2. Angiotensin 2 can do two things. It can increase blood pressure directly. It could signal for vasoconstriction. If you ever feel like you're craving salty things, angiotensin 2 can cause your brain to want salty things, but it can also signal to the adrenal cortex. So we'll talk more about the adrenal cortex in the endocrine lecture, but the adrenal gland will release aldosterone. And aldosterone is a hormone that'll signal to the distal convoluted tubule, right? ADH is the collecting duct. Aldosterone is the distal convoluted tubule. So it's going to signal to the distal convoluted tubule. And if we go to that right here, it's going to tell it to absorb more sodium chloride there. Well, what does that cause? So water is always going to follow the sodium chloride. Throughout biology, a good rule of thumb is water is going to follow the sodium. So if we're reabsorbing more of that sodium chloride at the distal convoluted tubule because of the aldosterone, we're going to absorb more water. And reabsorbing more water into the interstitial space can cause that water to be reabsorbed in the vasa recta, which is these vessels right in here. So if more water is being absorbed because of that into the vasa recta, we're increasing the volume of water in the blood. And increasing the volume of the blood will thus increase its blood pressure to counteract the original signal that was the blood pressure falling. That makes sense. Awesome. Cool. I am glad. Alrighty, so I'm going to hand things over to Josh. He can share his screen. If you have any questions, feel free to email me, set up office hours. Have a great rest of your weekend, and I'll see you next week.